Welcome, everyone. I know you're in the right place, so thank you for being here. Welcome to the AIM Center quarterly webinar, Advancing Inclusive Care, Integrating LGBTQ plus within collaborative care. I am Monica Williams with the AIM Center. I'm also joined today by my AIM Center colleagues, Sarah Barker and Esther Solano, who you see there on the screen. We are the AIM Center, and we are here to help support organizations implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. So the purpose of the AIM Center is to inspire providers of all types, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded. I feel like everybody says that these days, but we are. And we'll be sending out a link to the recording and the slide deck to everyone who registered. The webinar format accommodates a large audience today, and you'll see on your Zoom screen that there is a Q&A, a question and answer function. We're asking you to use that instead of chat. So if you enter your questions there for any of our panelists today at any time, but we'll only answer the questions after all of our panelists have concluded their presentations. So today we'd like to focus on questions on your experiences of these expert presenters. And if you have general questions about implementation or financing collaborative care, please bring those to our implementation or finance office hours. You can also check the FAQs on our website, and those are being put into the chat by Esther now. So our learning objectives for today, at the end of this session, participants should be able to identify key terminology and concepts related to working with LGBTQ plus patients in the healthcare setting, describe common health disparities and barriers to care experienced by LGBTQ plus populations in integrated care settings, and then also recognize opportunities within the collaborative care model to support inclusive, affirming, and equitable behavioral health care. Here is the list of today's panelists and presenters. We have the University of Washington represented, University of Iowa Healthcare, and Vanderbilt University Medical Center. So let's get started with setting the stage. So we'll get started with the University of Washington.
Hi, everyone. Welcome to the AIM Center's quarterly webinar on collaborative care for LGBTQ mental health. My name is Kay. My pronouns are he and him. I'm an attending psychiatrist here at Harborview Hospital, where we get to work with some of the most underserved communities of Seattle, Washington. I currently work in our integrated HIV clinic, where we serve a very large LGBTQ population. And this morning, I have the distinct privilege of starting off today's webinar by means of quick introduction to LGBTQ mental health. I mainly have two objectives for my talk this morning. I know that all of us come from a varying degree of experiences and comfort when it comes to working with the LGBTQ community. So I first wanted to sort of review the key terminology and concepts that are really important when working with LGBTQ folks. And secondly, I wanted to highlight some important health disparities. Now, as we dive into this topic, I do think it's really important to point out that there is no single monolithic LGBTQ community, right? It's rather a very diverse population that comes from all sorts of racial, ethnic, cultural, socioeconomic backgrounds. And so what we discussed today are largely based on data from the United States. I also think that the lived experience of the queer community could be very different in different parts of the world. So I thought it was important to say that. Next slide, please. So, the gingerbread man. So, let's first talk about the four interrelated concepts that are often mixed up and gets kind of confusing when we talk about the LGBTQ communities. And just note that these four ideas exist in a continuum, right? Separate but interrelated. So first we have sex, which is sort of a biological attributes assigned at birth, determined by things like chromosomes or gene expression or hormone levels. So examples of sex can include whether or not someone is a male or female or even intersex. And so again, it's largely determined by someone's karyotype. But related but different is someone's gender identity, which is really someone's internal felt sense of their gender. And I think it's really crucial to point out that this is a socially constructed idea based on sort of stereotypes that we assign as society, like roles or behaviors or even expressions that we associate with a particular gender. So examples include things like a man, a woman, a non-binary person, a gender fluid person might be someone who might have different experience of their gender based on what they're going through in the situations that they're in. Thirdly, we have gender expression, which is again a slightly different idea of what someone puts out for the world to see, right? So it's mostly visual and behavioral. So this can include things like whether or not you're masc or masculine, feminine, androgynous, or gender nonconforming. And lastly, we have sexual orientation, which is a really broad term that encompasses someone's sexual feelings and attraction towards another person. So this could be things like gay, straight, bisexual, asexual, pansexual, someone who might experience sexual feelings regardless of someone else's gender, or demisexual, someone who develops sexual feelings after an emotional connection that was built. You might hear terms like gray sexual, which is someone who might have sexual feelings infrequently. So a little bit confusing. So if I take myself as an example, I'm someone who is born a male due to my particular karyotype, who identify as a man, as in my sort of internal felt sense is that I mostly identify with the male gender. Expression is masculine-ish in the sense that I'm wearing clothing and hairstyle that might be associated more with the male gender whose sexuality is gay. So I think vocabulary like this can feel really intimidating, right? One, you don't want to offend people by saying the wrong things, and or maybe you don't want to seem ignorant, or maybe you're afraid that you don't seem like an ally if you ask what these words mean. But here's my take, which is that I think it's perfectly okay to not know. It's There are always new words that are coming up, identities that we're not familiar with, and it almost feels impossible to keep up sometimes. And so I do think that the most important thing is that we stay curious and respectful of another person's experience, right? So you could simply ask, what does this term mean for you? And how does this term allow you to make sense of your own experience in the world? Next slide, please. So when we talk about LGBTQ mental health in the US, I think it really starts with understanding the history of oppression and discrimination that these communities have faced. So for much of 20th century, same-sex sexual activities have been criminalized, right? It was punishable by imprisonment or even execution. Police raids were common. LGBTQ folks were often labeled security risk. They weren't allowed to hold government jobs. It was in 1969 that the famous Stonewall riot occurred, which really became the origins of our annual LGBTQ Pride. We just celebrated our 57th year last month in Seattle. Um, in the 80s, finally, some states began to ban discrimination based on sexual orientation. And it wasn't until 2003 that same-sex intimacy was legalized. And of course, in 2015 is when same-sex marriage was legalized, right? So the history of LGBTQ healthcare, I think, closely parallels the same arc of advancements. Homosexuality was initially classified as mental illness in the DSM, as we all know. There were a lot of medical treatments encouraged to change someone's sexual orientation, which is happening to this day. Outright refusal of care of folks who identify as LGBTQ was very common. Um, it wasn't until the 70s that the DSM finally removed homosexuality as mental illness. But then, of course, in the 80s and 90s, there was the HIV/AIDS pandemic that really affected this community really deeply. And it seems like it's important to note that there's a palpable backlash against the trans community in this particular age in this country. Next slide, please. So, with all this discrimination and stigma, it's no wonder that LGBTQ communities experience significant health disparities. One idea is to introduce a concept of minority stress, right? Minority stress is an excessive levels of stress that individuals from stigmatized groups might be exposed to, leading to increase in health morbidities. In this particular figure by Testa et al., authors propose that there are distal and proximal sources of stress, which is really interesting to kind of divide and think about. Distal stress comes from society at large, right? Interpersonal prejudice, social prejudice, discrimination, repeated rejection, maybe particularly from family of origin, victimization, assaults. And then proximal stress comes from within that person, like internalized homophobia, transphobia, uh, psychological damages of concealment, meaning living or being forced to pretend to be someone that they're not, right? And these can have real physiological changes. Chronic exposure to stress are known to activate, the HPA axis or the hypothalamic pituitary adrenal axis, increase in sympathetic tone leading to cardiovascular burden, metabolic syndrome, disrupted brain-gut axis, which we are finding more and more about, leading to, ulceration, IBS, and all sorts of GI issues. And of course, there are psychiatric effects of chronic exposure to stress that we all know about. I mean, I think virtually all diagnoses in the DSM will worsen with stress. Depressive disorders, anxiety disorders, bipolar psychotic spectrum illnesses. Stress is also shown to increase risk taking. So higher rates of HIV that we see in our clinic, higher rates of addiction and substance use. So all of these chronic exposure to stress from society and from within that person can really drive health disparities that we see in this country. Next slide, please. So some concrete data around this. There are a lot of great published studies. The one that I'm citing here is from the Williams Institute, which is sort of a research center in UCLA that publishes a lot of population-based data of LGBTQ communities in the US. If you look at the graph on the left, I'm sort of highlighting the suicidality that is experienced by the LGBTQ communities. This sample is based on data collected between 2016 and 2018. And note that it's in the bottom, but note that the background number or statistics of a person living in the United States, thought to be maybe around 50% of people experience suicidal ideation in lifetime, or maybe 3% of the people might experience actual suicide attempt. In comparison, when you look at the LGBT communities, the SI or suicidal ideation is experienced in the 70 to 80%, in suicide attempts, 20 to 40%. So huge, huge increase in both suicidal ideation and suicide attempts that one experiences in lifetime. In the graph on the right, looking at the same population sampling, but focusing a little bit more on the transgender community, basically that transgender adults had substantially elevated odds of nearly every mental health outcomes when compared to cisgender adults, psychological distress, substance use, suicidality. Next slide. Some of the other databases that are really great are the National Transgender Survey. This one is from 2015. I think there's a newer data from 2018 as well. Just really highlighting some key statistics experienced by the trans community. As you can see, the rate of bullying, rejection, violence is extremely high. And maybe what's even more concerning, the second bullet point, the experience of discriminations from healthcare provider. close to a third of people have experienced that in the past year. So these numbers are even more pronounced in trans women of color, who are much more likely to experience housing, employment, healthcare discrimination. And I think this is exactly why we are doing trainings like this, right? And why we are all gathered here this morning to really try to improve the experience of LGBTQ communities as much as we can, especially what's within our control in our healthcare settings. So next slide. So my portion is already coming to an end, but just highlighting the four main points that LGBTQ communities are diverse. And knowing terminology is important, but don't be intimidated to ask that person about what that particular sort of terminology and identity mean for that person. In appreciating the history of oppression and discrimination is really important in understanding why we are in the place that we are today, and just being really mindful about the rates that our LGBTQ communities experience in terms of violence, in terms of discrimination, especially in the healthcare setting, and how that translates to their levels of stress and their outcomes and their medical symptoms, but also psychiatric symptoms. Thank you.
Thank you so much. We are going to transition over to the University of Iowa healthcare team.
Okay, thank you, Monica, and thank you for that excellent overview to kick things off. So my name is Mike Strong, and I'm a consultation liaison psychiatrist here at the University of Iowa Healthcare, where I help oversee our clinical operations in the Department of Psychiatry and have worked on implementing the collaborative care model across primary care settings over the past few years and throughout my career. So next slide. To begin, I'll briefly orient you to our health system and the clinical setting in which this work we're going to discuss today was developed. To start, UI Healthcare is a large academic health system in the Midwest. We have approximately 20,000 employees, 1.3 million ambulatory visits a year, 1,000 patient beds, and roughly 34,000 acute inpatient admissions annually. Our LGBTQ clinic was established in 2012 and has now served more than 4,000 patients. The clinic includes more than 25 clinicians across primary and specialty care. And one important feature of our program here is that it operates through a decentralized model. So clinicians with expertise in LGBTQ care and healthcare are integrated into established primary and specialty care teams rather than located within a completely separate clinical structure. So while that approach expands access to affirming care across our health system, it also creates some implementation challenges when it comes to integrated care and the collaborative care model specifically. So behavioral health services, clinical workflows, and staff practices need to remain coordinated and affirming across multiple teams and settings in this context. So with that established infrastructure, it gave us a strong foundation to work with, but it did not eliminate the behavioral health access problems facing many of our patients. And so highlighted here is, and as we've already heard about, transgender and gender non-binary patients experience substantially higher rates of depression, anxiety, suicidality, and other behavioral health concerns. But the problem is not simply greater symptom burden. Patients also face significant barriers when they try and access care. So this can include discrimination, prior negative healthcare experiences, and a limited number of clinicians with experience providing affirming care. On top of this, care is also frequently fragmented. So a patient may receive primary care in one setting, behavioral health care somewhere else, and gender affirming treatment through another team. So each additional referral can introduce a new wait time, another intake process, and uncertainty about whether the next clinician or workflow will be affirming for patients. So collaborative care, as we're all here to discuss, it offers one potential response by creating a structured pathway to behavioral health support within the primary care environment where patients are already receiving care and have often established and trusting relationships. However, it does not eliminate the need for specialty psychiatry, as we'll discuss, things like longer-term psychotherapy or higher levels of care. However, the hope is it provides lower barrier entry for assessment, brief treatment, measurement-based follow-up, consultation, and escalation of care when needed. And so kind of setting the background in what we've established here at the University of Iowa, and with the background and context here, I'm going to turn it over now to Dr. Mborick, and she's going to describe how our team structured and adapted the collaborative care model at the University of Iowa.
Thanks so much, Mike. So my name's Katie Mborick. I'm a family medicine physician, and I am one of the members of the LGBTQ plus clinic team. So in family medicine, in our health system, we have 18 primary care clinic locations, and it just so happens that at the practice location that I'm at, this is where we started doing our collaborative care pilot. At this specific location, we have 10 family medicine providers, both physicians as well as advanced practice providers. And of those 10, 4 of us are part of the LGBTQ plus team. So this is kind of how we ended up doing this pilot in this clinic, where there is, again, this kind of decentralized model for the LGBTQ plus clinic within University of Iowa Healthcare. So our model was really structured on kind of the collaborative care model, where we have the primary care provider, so in our case, family medicine, and then we have the behavioral health care managers, and then the psychiatric consultant, Dr. Strong and one of his colleagues. And so that core model is still there, but because we knew that a lot of our patients would be members of the queer community, then we really sort of thought about how we would implement or think about implementation to make sure that we were providing the most inclusive and respectful care that we could. And so some of those things are already incorporated into our EHR, like inclusive documentation, just in the sense that we know if we get that information about their SOGI status, that it's going to be kind of spit out in other ways. Everyone in our clinic, because we've had these 4 providers there for so long, they're fairly well versed on affirming communication. Team training is something that we have done and continue to do, and one thing that we offer to the behavioral health care manager, because this patient population is just so represented within these providers. Measurement-based care, like always, with PHQs and GADs, and then patient-centered workflows. You can go to the next slide. So when we think about standard CoCM versus, in our case, the affirming CoCM that we did, same elements with that standard CoCM. So measurement-based care, really relying on PHQ and GAD to both identify patients, but also kind of measure the efficacy of our interventions. That team-based consultation, be that in person or be it via telemedicine. And then that primary care integration, where this collaborative care team is really integrated into our primary care family medicine clinic space, and then the care coordination that we get with the behavioral health care manager. So what we specifically did was kind of adapt it and to really focus on gender affirmation. One of the important things that I think that we could call out here is a number of us in the LGBTQ plus clinic, because as we've already talked about, we have mental health disorders that are so overrepresented. We get a PHQ just based on our logic, more so than our other providers might have in their kind of questionnaires linked to visit types. So we're getting this information a lot more regularly. It's probably highlighting the fact that some of our patients are suffering from mental health complaints. And so we're just more apt to want to use the service and to get the patient the help that they may need. Our team really understands kind of how to do gender affirming care, how we should be really thinking about mental health conditions in this population. And then finally, kind of just being able to normalize that behavioral health care within an affirming primary care environment is something that we offer and that we care about. It's not just about their hormones, but we want to take care of the whole person. And then finally, as I mentioned, in our EHR, we do a really nice job in everyone across our system of making sure that we have preferred names and pronouns, and that patient's autonomy is protected. So when we put that consult order in and some new care team member might interact with that patient, it's pretty easy to see what their sex assigned at birth is, what their gender is, what their names are, what their pronouns are, to make sure that we're not misgendering that patient and treating them with respect. I'm going to hand it over to my colleague now, Ainsley Shefford, to talk a little bit about our pilot research study that we did.
Good morning, everyone. I'm Dr. Ainsley Shefford, Assistant Professor with the School of Social Work at the University of Iowa, and I have had the great honor of working with this fabulous team for the past several years. And as part of our work, we evaluated our initial collaborative care model pilot, which went from November 2023 to May 2024, using a retrospective pre-post chart review in the EHR. This allows to ensure that our analysis is really looking at what happened, what actually happened. And so the sample included 33 adults who completed a full episode of care. 15 were cisgender and 18 identified as transgender, gender expansive, or gender non-binary. And we examined changes in depression and anxiety using the PHQ-9 and GAD-7, and also explored whether those outcomes differed between the groups of cisgender and transgender, gender expansive patients. You can go to the next slide. Thank you. So among the transgender and gender non-binary patients, we saw significant improvement in both outcomes. Both average depression scores and anxiety scores decreased from intake to the end of the episode of care. And these findings suggest that the adaptive collaborative care model produced meaningful clinical improvements for our LGBTQ clinic population. You can go to the next slide. And then when we compared outcomes by gender identity, we found comparable improvements between cisgender and transgender gender non-binary patients. Both groups experienced reductions of about 4 points in depression and 3 to 3.5 points in anxiety, with no significant differences between groups. And this suggests that the adaptive model does show signs of being similarly effective across gender identities. With that being said, these findings should be interpreted in light of several limitations. This was a small single-site pilot that used retrospective chart data and included only patients who completed a full episode of care. Without a comparison group, which we are working on, we cannot attribute these improvements solely to the collaborative care model, and the small sample limited our ability to examine differences across larger patient groups. Still, these results do provide promising preliminary evidence to support continued implementation, and we will continue to do more evaluation and increase the rigor of that evaluation as we are able to. Next slide, and I will turn it back to Dr. Strong and Dr. Mboric.
Hey. Well, thanks, Dr. Shepard. And to wrap things up for us, our team wanted to highlight kind of 4 practical lessons that we've taken away from this work thus far. And so first, that starts with trust and relationships. Affirming care needs to be visible before patients have to request it. And I think part of the experience that we've had is, as Dr. Mboric described, this clinic has been well established for several years, and so much of that trust and importance of those relationships was already built in. And so we had a leg up in implementing this model in that context and setting. Second, the importance of training the whole team. And so the patient experience is shaped not only by clinicians, but also schedulers, front desk staff, care managers, consultants, and even the electronic workflows surrounding care. The third piece would be building affirmation into the system at all levels. So names, pronouns, documentation, confidentiality, the follow-up and referral pathways, they cannot depend solely on the knowledge or goodwill of an individual clinician. It really takes the entire system and team being thoughtful about this. And then finally, tracking equity rather than only the aggregate outcomes. So Ainsley highlighted some of the common metrics we look at in these models, so PHQ-9 and GAD-7, but thinking more also about how did patients access care, did they engage, how did they complete and respond to that care, and what was their patient experience or preferences? So those are all questions that we're going to continue to explore and want to look more directly at moving forward. And then just a note on my own experience in working with the team here and experience in collaborative care implementation. So my experience began during my fellowship training at the University of Pennsylvania, and was fortunate to step into an early faculty role implementing collaborative care across traditional primary care settings and seeing that in a really mature and high-performing setting. Then to shift in how I brought that back to the University of Iowa and expanded this into the LGBTQ plus clinic here, one of the first things we did was ask the question, is anyone else doing this? And that's where I think we all were excited for today's webinar to hear from others' experiences. When we asked this question, I actually sent an email out to the national listserv for collaborative and integrated care through the CL psychiatry world. And, unfortunately, I only got one response, and that was from a fairly, established gender affirming care clinic. And part of the advice given through that is, the needs of this patient population may be more than traditional collaborative care can meet. And so using some caution if we were going to roll this model out, and some hesitancy about whether it would meet the needs and complexity of this population. And so that wasn't discouraging so much as just energizing and asking an important question. Does, the potential for greater average complexity make collaborative care inappropriate, or does it actually mean that we should lean into this model more and think about how it can really help with assessment, treatment, and escalation of care as necessary? So as Dr. Shepard mentioned, our pilot doesn't completely or definitively answer this question. It was small, observational, and kind of limited in the size of our sample. At the same time, we've been really encouraged and energized to move forward, and in particular, as we've met with other groups who are doing this work across the country. And so the broader conclusion for us is that it continues to be a model that's scalable, evidence-based, and integrated into primary care settings, especially when there's opportunities to really help close some of the disparities and gaps introduced at the beginning. So with that, I want to make sure that we have time to hear from our colleagues over at Vanderbilt, and we'll wrap things up for now. Thank you.
Thank you. Opportunity is what I hear in that. So thank you so much. Going to transition over to our Vanderbilt University Medical Center team.
Wonderful. Good afternoon or good morning, depending on where you are, everybody. Thank you so much for letting us join. My name is Dr. Chris Turndrup. I'm a general internist, clinician educator, a primary care provider focusing on LGBTQ plus patients, and I'm the associate program director for our one-year LGBTQ plus fellowship here at Vanderbilt. Really excited to hear about amazing work happening in Iowa, and thank you for the lovely introduction from our colleagues at the University of Washington. If we could go on to the next slide. My last role here at Vanderbilt is the medical director for what we call Vivid Health. It is our virtually connected group of team members from multiple different professions, multiple different disciplines. And we have come together over the years to support LGBTQ plus healthcare here in Middle Tennessee. And I'll say Middle Tennessee, knowing that we actually pull patients from really across the state and even from other states nearby. Kentucky is very close to us here in Nashville. We get patients from Alabama, Georgia. And so what we built from was a relatively small, previously called a transgender clinic. There was a medicine pediatrics provider and a nurse practitioner who were really starting off offering hormone therapy. And we rebranded that clinic as the desire to contribute to that work grew amongst team members at Vanderbilt. So we wanted to be more broadly caring for both sexual and gender minorities. And that was also part of this LGBTQ plus healthcare fellowship funding that came from both the AMA and Tawani foundations. And we continued to collaborate with folks through the AMA Foundation's Fellowship Consortium, which also gives us opportunities to kind of learn along with other teams across the nation doing this amazing work. So I've had the distinct pleasure of trying to coordinate the care across multiple different clinics, bringing providers and team members together to really provide this amazing care. And if we could go to the next slide, when I first arrived at Vanderbilt, I tried to put an org chart together and it was rather difficult. But I do like to put things on our Pride Progress flag here, knowing that we have medical services across primary care, we have endocrine consultations, we have people working in our, it's separate but very much related HIV clinic as well. We've had some changes to our surgical program. I won't go into the details on that today, but very much integrated into the care that we were providing people in plastic surgery, gynecology, urology. And really important to highlight here is our growing behavioral health footprint. And we've been working together. All of those team members meet weekly on a virtual call, often talking about some of our complicated cases, allowing us to collaborate and coordinate care across these different disciplines. And that had been part of how Vivid came together. So working in this virtual context, collaborating without being co-located was really part of the way the clinic was already functioning. I will point out we know that the clinical services that we provide in the top three colors there are really foundational on top of the amazing community engagement by our program for LGBTQ plus health that had been in place for many years, as well as the education and research efforts that we continue to hope to build. So in the next slide, I'll get more specific into our collaborative care model. When I arrived at Vanderbilt, collaborative care was really struggling to get a foothold in primary care in general. There was difficult uptake with the primary care providers. The financial stability of the program really hadn't come through. And in 2023, someone you may hear from shortly, one of our chief residents in psychiatry sought to create a version of collaborative care specifically for LGBTQ plus patients, having seen the distinct need among that population as she was seeing them during her residency. And so, as I was describing collaborative care, specifically working in a virtual space, worked really well for Vivid Health already. And we'll go into some details in a little bit, but over the past few years, it's been uh, broadly uptaken by the providers. It's been incredibly impactful for our patients. And we were lucky enough to have this going on, especially as the political and social environment around us, not only across the nation, but also here in Tennessee, got increasingly chaotic and stressful for patients and team members alike. And the lucky thing about the amazing work that my colleagues have already done is it's been shown to be financially beneficial. And even despite being in tough financial strains and being in a hiring freeze, they allowed us to recruit for growth because we were been shown to be so impactful and also financially stable. So again, I represent one of the primary care providers and also a medical director that helps bring team members together. But I'm going to turn it over to my amazing behavioral health colleagues and let them talk to you more about the collaborative care model. And we'll start with the amazing Sarah Schott.
Hi, good morning, good afternoon. I'm Sarah Schott. I'm a clinical social worker with Vivid Health. I'm going to talk about how our behavioral health services were operating before and after we implemented collaborative care. Prior, of course, Chris highlighted that the Vivid Health Clinic is based in this multidisciplinary work. And so, as the clinical social worker and along with a colleague of mine, we were part of that multidisciplinary team. But we found that psychiatry was maybe operating not as synchronously with us. The PCPs were working occasionally with them for one-time psych consults or maybe some ongoing care. Myself as a social worker, I was not having contact with our behavioral health colleagues. And so maybe that was leading to not totally synchronous care being provided to our patients, despite the fact that the Vivid team met every week. The psych consult maybe wasn't at that meeting to discuss these cases with us and provide their input. So next slide. In implementing CoCM, we have created this kind of miniature team within our Vivid team, which consists of primary care, the behavioral health care manager, myself, and my colleague Holly, who is another LCSW, and our psych consult, Christina Alton. And so we have the privilege of meeting weekly, separate from our Vivid team meeting. We also meet with Dr. Alton every week, and we're getting to dig in deep about our behavioral health patients within Vivid. And this is allowing for medication management, the psychosocial needs that we're meeting, as well as their medical needs that are met by primary care, to be addressed together as a team, and hoping for better outcomes for these very complex patients. I'll pass it over to Christina to get a little bit more in depth.
Thanks, Sarah. I'm Christina Alton. I'm a general adult psychiatrist at Vanderbilt. And as Dr. Turndrup mentioned, I was also a resident here for 4 years, and I'm now in my second year as an attending, and really lucky to work with the team that has been built around me to do this collaborative care work. So I'll just talk a little bit about some of the clinical work that we've been doing. Some of this has been covered by other presenters, so I will try to focus on the unique features of our program. On this slide, we have on the right this pie chart just showing what the breakdown is of gender identity for the patients that we are working with in our collaborative care program. This data was taken from when we had about 100 people enrolled in the program. Our kind of unique psychiatric conditions that we see in this population are there's a lot of neurodivergence, so autism, ADHD, OCD, and in general, just very high rates of trauma-related disorders as well. We also, because we work in this very multidisciplinary large healthcare system that also offers surgery, again, Dr. Turndrup mentioned there's been some changes in that recently, but is still an active arm of our multidisciplinary group. We also, in some of our collaborative care patients and work with like letters of support for surgery, which is also a unique feature of this collaborative care program. When we were at our peak of patients that we were seeing, we had 106 patients enrolled. We had one of our LCSWs left Vanderbilt, and so we were operating at kind of half capacity for a while. Recently, we're really lucky to hire a new LCSW, Holly Lucky, and so are working through our wait list and getting our census back up. We have 57 people right now. We give out the patient-reported outcomes measures of PHQ-9 and GAD-7 to all of our patients enrolled. We have had some challenges in the uptake of consistent PROMs going forward and on discharge, which is one of the challenges that we are working on right now. But we can go to the next slide. Here, this is less outcomes and more of our intake data, just showing the kind of burden of at least GAD-7 and PHQ-9 scores for our patients. Again, I've had more challenges in getting those outcomes measures completed by patients on subsequent visits and on discharge. It's something that we're actively working on getting to be a little bit tighter so we can get some better data on what our outcomes look like. But over half of our patients come in with at least moderate to severe GAD-7 and PHQ-9 scores, which looked similar to the data that I was presenting to. So high burden in this population. But again, GAD-7 and PHQ-9 doesn't entirely capture the things that we work on clinically, which again, a lot of neurodivergence, ADHD, OCD, PTSD, things that might not be captured in these measures. You can go to the next slide. I have just an example patient here who gave permission to present in an anonymized way his story to kind of highlight how our collaborative care model is integrated into our larger healthcare system. Each of these bars going across is a specialty or a team member, and this is in chronological order, going from left to right. This patient came in actually through our plastic surgery program, had gotten a consultation for phalloplasty, and through our usual workflow there, had been referred to psychiatry first actually to get a letter of support on that initial consultation. Noticed that this patient needed a primary care provider who was affirming and to get replugged into gender affirming hormone therapy, and so referred actually to primary care from psychiatry. And then this person was identified as a good candidate for collaborative care, and so kind of came through in that atypical route. But for our multidisciplinary team, there's often these different directions that people come into our program through. So for this patient, we had some consultation, like with our in our weekly meetings, recommending medication changes and initiations. Patient met regularly for therapy sessions and was moving forward with the surgery planning, which was a very stressful time. We ended up also referring the patient to our partial hospitalization program that we have here at Vanderbilt to kind of shore them up with more skills and resiliency to get through the post-op period. They ended up having their first stage of phalloplasty here with us and did really well with that, and then did really well from a mental health perspective and moved to as needed visits. So it's just one example of how our patients move through our program and operate in our larger multidisciplinary team. You can go to the next slide. These have been addressed by some of my co-presenters, so I won't reiterate them here. I will just add that there are like special needs in this population in terms of transparency and privacy concerns, particularly in our state and our institution. There are some recent events that make this a priority that we are really attentive to making sure we are really transparent with patients about, what we document and, what vulnerabilities exist in the medical record for them. So that's something that also comes up often when we are working with this population. And next slide. Thank you.
All right, thank you so much, Vanderbilt team. As we are having attendees put their questions into the Q&A, I just want to thank you all as panelists. It's really valuable to hear from those of you who are stepping up to make the necessary modifications, take the opportunities, consider political climate and all of those things, and making the changes that need to be made for your clinics and the individuals in your clinics that have a need, and your willingness to share it. So to share that, your learning and your lived experiences of doing this work as you've gone along the way is really helpful for the rest of us. So we thank you for that. And I am going to transition us over to our Q&A portion. So everyone will be spotlighted at this time so that we can begin to answer questions that were posed into the Q&A section. And so I'll turn it over to Sarah Barker.
All right. Well, while the audience is thinking about questions, I have a question for the panelists. This fabulous presentation. I'd love to hear a little bit more about how given high rates of suicidality that we heard about from Kay earlier, how you have thought about incorporating like suicide safer care pathways into your programs from screening, identification to management, and like how you do that at Vanderbilt in Iowa, if you wouldn't mind sharing as others are thinking of questions. Either team. Anyone want to go?
I can jump in. So at Vanderbilt in the primary care space, so patients are generally completing their depression screenings beforehand, and we actually get a pop-up notification when we go into the patient's chart if there was concern for suicidal ideations. And so that kind of gets the pathway started and allows us to start our assessment. I would say that I'm very lucky as a primary care provider that the team members are generally quite available to help me with my assessment if this is truly an emergency or if it's something that we can get the patient connected relatively quickly for support. So we're lucky in that regard. Generally speaking, these are patients that we know very well. Sometimes they may deal with more chronic suicidality, and it's something that we can just continue to integrate into their care. But when we do have a new concern or someone that needs additional support, we're lucky that we can reach out to our colleagues at the time of the visit for additional help. Christina, Sarah, if there's any other kind of follow-ups that you would see, happy to have you chime in.
I agree. I think that collaborative care has been beneficial for those pathways in the sense that we have a stronger relationship with our colleagues at Vanderbilt Psych Hospital and being able to connect people with a higher level of care if necessary within the system.
I agree.
Yeah. Sorry, Christina, please go ahead.
I was just going to add that, yeah, we're also lucky to have intermediate levels of care like intensive outpatient and partial hospitalization for those folks who may not be in a an acute crisis that requires an inpatient facility, but could use some additional support beyond what collaborative care can offer them. So we often connect patients to those programs as well.
Yeah, and I'm happy just to talk a little bit about how University of Iowa Healthcare does this. And first, Chris, we may have to connect offline about kind of that pop-up that highlights any positive questions around suicide and self-harm. We similarly give our questionnaires to patients and have limited kind of the time because we're afraid of that risk, that we don't want them to answer that questionnaire 5 days ahead. So they have to do it on that same day, so we don't leave something out there without appropriate follow-up, but that would even be more helpful. And I would say that the majority of our patients do kind of have more chronic suicidal ideation, and our providers are well versed in kind of doing a follow-up assessment, whether that's maybe the Columbia or whether they just kind of ask those follow-up questions. I think one of the great things about CoCM is just that we know that we can sort of ask, like, when are you going to follow up with your, outside therapist? But we also know that if they're in our CoCM program, we're just going to message our behavioral health care manager and say, hey, call this patient tomorrow, reach out to them a couple times because they're really struggling, so we can keep a closer eye on them and know when we can escalate care into some sort of higher level if needed.
Yeah, the only thing I would add there, Dr. Borick, is, agreed that there's opportunity for us to think about how we're notifying providers of suicidality as it comes up on screening. But when we did roll out kind of very thoughtfully when and how the screeners were administered, we did add on the front end some kind of direct in Epic and in my chart review of crisis resources. So when they go to fill out those screeners, they see reference to 988 or other local crisis services. And then I was thinking back to some of the more acute and challenging cases. We also, fortunate in our health system to have a crisis stabilization unit, kind of low barrier as well. And so part of bringing the team together into the health system was making sure that our care manager had met people in the outpatient clinic and the partial hospitalization program, but also our team in the emergency room and the crisis unit, so that there's that opportunity for continuity and warm handoffs when needed. But I would agree with what else has been said already.
Great. Well, we have some questions coming in. The first one, thank you so much for this presentation. As a BHC, I struggle when my team of PCPs considers themselves as gender affirming, but struggle to consistently utilize appropriate pronouns. I find this a big barrier to care and continues to affect our clients. Would you have any suggestions for my team and I? Kay, you might want to weigh in on this one as well.
I think that's such a great question. And I think it's a really difficult thing, because what you're asking someone to do is to really change the way they think about pronouns, the way they approach people's names and titles. And so I think it's a cultural shift. And I think it's not a simple change. I think approaching, I'm sure this person who's asking the question is not so gender affirming and already are working on this, but approaching it with empathy and maybe practicality, really keeping the explanations simple, maybe saying something like, using the correct pronoun is like using the correct name or using the correct title, like you would call a physician a doctor, and sort of keeping it simple rather than kind of going into this the history of pronouns, and then maybe normalizing the mistakes that we all make mistakes, and a lot of us working in the gender clinics, we make mistakes, and so the virtue of making mistakes in itself is not wrong, and it's really about focusing on the respect, and kind of what we talked about in the talk about curiosity and respect, and focusing on that instead of sort of correcting errors might be a good approach.
Great, good tips. Thank you. For those that support clients with gaining gender affirming letters, is there a session minimum you have for attendance within collaborative care to provide that letter of support? How do you kind of go about doing that?
I can take this one. So within our program at Vanderbilt, there existed before collaborative care this pipeline of from the surgical consultations to our behavioral health providers who do gender affirming letters of support. There's no specific minimum within that program either for a patient to have to obtain a letter of support. It really depends on clinical need and complexity. Oftentimes, these are very straightforward evaluations, especially when patients have been seen by our primary care for gender affirming hormone therapy, have been seen by our surgical colleagues, and have really already gone through a lot of evaluations establishing the diagnosis of gender dysphoria. And those can be one-time visits with the behavioral health provider to actually write the letter of support. But for those that are more complex, there is flexibility to have multiple sessions if there needs to be more clarification or exploration of gender identity to really establish those criteria that are required by WPATH for gender affirming letters of support.
Thank you for those tips. Maybe how about this question about in our program, there's an issue where patients come to collaborative care and it becomes evident they need a higher level of care. This happens, I know. Yet we are unable to find a referral that takes their insurance, especially Medicare B or Medicaid, and is accepting new patients. Do you have any tips on navigating this? I'm sure it happens to both your programs.
I'll try and take a stab. I do want to hear what other people have to say. What a
Yeah.
difficult thing, because we all will struggle with this.
Mhm.
This is where I think having a well-connected network of people that can also collaborate with community organizations to try and hear about what other options there might be in the community. We try to keep an active referral list and update it periodically to make sure that if a patient does need to seek a higher level of care and it's not something that we can provide, that we can at least try and get them connected to the community. We're seeing a lot of this now, particularly with lots of people losing their jobs and therefore their health insurance. So I think it is something that's going to be a bigger problem moving forward. So I find that keeping an active outside resource list can be really helpful.
Mhm.
Thanks, you guys, for those. I have to cut us short. I know there's still a few other questions in there, but I have to cut us so we can have transition time. Thank you all for answering those questions that have come in from our attendees. For those of you who are on the call or are listening to the playback, here are some additional resources for those who may be interested. Many may know, some may not, that we do this quarterly webinar series and have been doing it for about 2 years now. I think it's been maybe 3. So our next quarterly webinar will be on October the 20th. So look for information to come out about that soon. In order to continue to provide this amazing free resource and to have others come on, we do inquire and want feedback from you. I always say feedback is a gift, and every day is my birthday, so bring on all of the gifts. So please fill out feedback on today's webinar. There's also a place on there for you to put future topics that you are interested in hearing about, and that's how we then create our programming. Esther has put that link in the chat box for you, so if you would please grab that. If you are not already connected with us on LinkedIn, please do so. And here's the information for that. And then a little special shout out to our co-sponsors for today's webinar, The Birch. So there's information on The Birch, and then we also have their contact information here at the end on the slides. So want to give you all a little transition time as you go into the rest of your day, seeing your patients, taking care of individuals who are near and dear to us all. So thank you for attending today's webinar, and I hope you have an amazing rock star rest of your day.